Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. In today's episode of Mapping Healthcare, the tables are turned. I am the guest on the Walk and Talk Improvement All Ireland podcast. The goal of this podcast is to improve quality in healthcare in Ireland through the stories and experiences of people who work in and use health services. This is a special episode to mark the 2025 World Patient Safety Day. This is an annual campaign organized by the World Health Organization, and naturally, I was thrilled when I found out a few months ago that this year's focus was about a big problem that affects our smallest people. The 2025 theme is Safe Care for Every Newborn and Every Child, and it highlights the need to prevent avoidable harm in child health settings. In today's episode, I'm interviewed by Dr. John FitzSimons. John is a consultant pediatrician at Children's Health Ireland in Dublin. He also works with Health Service Executive, National Quality and Patient Safety, as their clinical director for quality improvement. The Health Service Executive is the publicly funded healthcare system in Ireland, and it provides health and social care services to everyone living in the country. John and I talk about some of the unique features and risks in the care of newborns and children that must be tackled to make sure their care is as safe as possible. Hope you enjoy this episode.
Hello, and you're very welcome to episode 29 of the Walk and Talk Improvement podcast. And today's podcast is a special collaboration with our guest contributor, Dr. Ulfat Sheikh, and her podcast, Mapping Healthcare Podcast. Ulfat, you are most welcome to the Walk and Talk Improvement podcast.
Thank you, John, for the invitation. It's a pleasure to be here.
So, Ulfat, you are a medical director of healthcare quality and professor of pediatrics at University of California, Davis in Sacramento, California. And you're a board member of ISQA, the International Society for Quality in Healthcare. But you, like me, are also a pediatrician.
Yes, I am. I've been a pediatrician for about 25 years and have really appreciated this journey taking care of the littlest members of our society and their families.
Fantastic. Well, it's great to have you here to speak to another pediatrician who's interested in patient safety and quality, because today's episode is marking the fact that WHO World Patient Safety Day is about children and newborns. And this year, the theme is Safe Care for Every Newborn and Every Child. And their slogan this year is Patient Safety from the Start, which I think is pretty worthy, as I imagine you do too.
Yes, it was really cool when they released that theme and highlighted the role of pediatrics in making sure that our patients receive high quality and safe care.
Yeah, so it's great to see pediatrics being recognized. And of course, we recognize newborn care and neonatology here as well. It marks a particular point of progress in pediatrics. We've seen great improvements and strides in the quality and patient safety of care through innovation. I'm thinking of newborn care, all the things we can do now in the neonatal intensive care, all of the great achievements that we've made in vaccination. In Ireland this year, we're going to roll out the RSV immunization to cover the whole of the first year of life. So babies born now after the 1st of September will get the immunization as they are born. But those who are under 6 months in September can apply and receive their vaccination. That's transformed the quality of care and preventing these illnesses that cause not only the misery of illness, but they also put children in harm's way and the risk of patient safety. But I think at this stage, being able to reflect now on what does patient safety in pediatrics and newborn care look like, and I think that's maybe where I'd like to start. I did a paper a few years ago where we talked about harm-free pediatrics, and in that we talked about minimizing pain and distress, no tissue injury, no medication injury as much as possible, no hospital-acquired infections, early recognition of procedural complications, of sepsis, of safeguarding issues, and avoiding unnecessary care. And then finally, making sure that people had a positive experience, avoiding psychological harm. But that was 10 years ago, Ulfat. Do you think things have changed? Are there things that we should be adding to that list of what harm-free pediatrics and newborn care looks like?
So, John, that's a really comprehensive list, and pretty much everything that you mentioned in that list still applies. But I think that there is a modification in how some of that work is being done. Since that time, you mentioned about a decade ago when we started selecting these areas of high priority, there's been a lot of progress in standardization, creating protocols for children. Of course, there's information technology that has come in. And with that, I think there has been some evolution in how the thinking around these topics has progressed. So, just to give you an example, in the last 10 or 20 years, I've seen the electronic health records or EHRs really change how we practice care. It's really improved communication. It's really been a game changer looking at things like errors related to people not noticing lab test results that come in, or for our littlest patients, like even weight-based dosing that we used to calculate, right, using our calculators or in our heads. Now that's been automated. But again, the thinking around patient safety has evolved because although medication errors still persist, now we have this nuance of looking at how we can program our EHRs to make them pediatric friendly, customize them with weight-based dosing, body surface area-based dosing, infusion pumps, right, that can be programmed now. So although those areas that you highlighted still exist, I think that with the progress we've made in health technology and our standardization, just how we approach them has really changed. Another area that we can talk about a little bit later is a simulation-based training, and that's just an opportunity for great improvement, and I think is worth discussing in the context of pediatrics.
Yeah, certainly simulation, I think, globally has become a great tool for practicing what it means to be safe. We're making some progress here with electronic healthcare records, and I think all of those things will certainly play a role. I think when we move to our new children's hospital, I work in Dublin and we're about to move to a new children's hospital, hopefully in the near future. And I think all of those things will be enabled by the technology. What about the theme last year's Patient Safety Day was diagnosis and diagnostic problems in pediatrics? Do you think that's an area where we could do better in?
Yeah, for sure. Pediatrics is special in many ways. But one of the things that makes it special is the fact that it's not just the child, right? That's our patient. It's their caregivers, their family members that come in. Because a lot of the history that we take during pediatrics is not just from the child, but also from the family members. All of those nuances come into play, right? Trying to have family-centered discussions, family-centered history taking. So diagnosis is a bit different in pediatrics because you're trying to figure out when a really fussy, unhappy child comes into your office, what's bothering them. It's just really up to your experience and skills and being open to those symptoms which look different in kids. And then, of course, there is the shared decision making and shared history taking around the family members and filtering that as well, trying to check our own biases and cognitive hurdles that come in the way just to make sure diagnosis is excellent. So, of course, yeah, lots of room for improvement in the pediatric diagnostic excellence space as well.
Yeah, thanks. I think one of the big things for practicing safely in any area is being aware of the risks within your context. And I'm always amazed when we think of pediatrics and the risk changes when we think of tiny neonates being born at maybe 500 grams, and then you work in an adolescent unit where maybe some of your patients could be over 100 kilograms. That's a 200-fold change in body size. Now, I'd like to see our adult colleagues deal with that risk, but our risk is different in pediatrics and it changes throughout the course of a child's life. How do we deal with that?
Yeah, so you bring up a really good point. The variation in patients that pediatricians and pediatric healthcare providers have to deal with. So, as you've heard and you live that life, right? Like we've been experiencing that adverse events can, affect up to 1/3 of all hospitalized children. And, the risk is high, as you mentioned, in intensive care settings and emergency departments as well. And children are at a greater risk of medication errors than are adults and, many other issues as well because they develop along a continuum that is variable. Each kid does their own thing and we just need to figure out what's normal variation and what's abnormal. There's, of course, differences in demographics. And of course, our adult medicine colleagues face that too. But in pediatrics, we depend a lot on parents and other care providers at home. There's different epidemiology of medical conditions. Kids are smaller in weight. Their morphology needs a suitable healing environment. Our dose calculations, as we discussed, are weight-based, body surface area-based. And really, one other important thing we see in pediatrics is around the issue of decision making and legal status. So there's, minors, we still engage parents in consenting for treatments as we should, and informed consent is delegated to parents. So care is really complex in pediatrics and really needs to be holistic. This sets us up for potential issues, but again, I think the opportunities lie within engaging families and making sure that our diagnosis and decision making is around the system of care that surround a child.
And I think that's one of the things that's probably changed, certainly in the 10 years since I started talking about harm-free pediatrics, is who's on the team. There's an effort now to try and involve families, certainly parents and carers and guardians, but also, where appropriate, our patients themselves. Have you seen anything that works well in bringing families into becoming part of that safety team?
One evolution that I've seen in pediatric care delivery over the years is family-centered rounds. That has been really revolutionary in making sure that everyone's at the bedside that cares for the child.
What actually happens in a family-centered round?
There could be some variation depending on the context you work in. You have to consider how much the family wants to be involved in this. You just can't expect all families to have the bandwidth as well as the economic ability to engage in the way we expect them to. Typically, back in the old days, we would do our hospital rounds and it would just be a bunch of healthcare providers around the child, and we'd have our discussions in medical terminology and have come up with a plan in medical terminology. And then if by chance the family member happened to be around, we would talk to them about it. But thankfully, that model has gone away for the most part, hopefully. What we moved into is trying to have families at the bedside when we're conducting these rounds. And you can do it in creative ways to make sure families can be there. We've used telemedicine or video conferencing when appropriate to have families engage in these discussions. We've changed the time we do these rounds to make sure family members who want to be there can be there. We have family members who need to be at work in order to pay the bills, and being at these rounds is not family-centered for them, and trying to see how we can get their feedback and input in other ways as well. So essentially, you have the family there when you're making key decisions essentially, and make sure that you run these by the family, try to get their feedback on how feasible they are for the family, what their thoughts are, what you missed, right, in your thought process. Again, as I mentioned, depends on the context. What works for one family doesn't work for the other, but really has been a step in the right direction.
Yeah. And it's really, I suppose, isn't it, recognizing that families can see stuff that we just can't as healthcare professionals, that they know their children better than anybody else. And especially children maybe who have a disability that impairs their communication, or maybe they have observations that are hard to interpret without that family knowledge that's there.
Yeah, I think a part of that has to do with humility on the part of healthcare providers. I work a lot with kids with complex conditions, with kids with special needs. And really, the family that comes in with that child knows that child obviously much, much more than I ever will. And so trying to step away from that hierarchical approach that we previously had in healthcare and trying to approach that family with a sense of humility, knowing that they are the experts on their kid and you are basically helping keep their child healthy, I think is a cultural change that has entered healthcare in the last decade or two.
And one of the key campaign messages of this year's World Patient Safety Day is that safe care depends on safe systems and teamwork. I don't think either of us would disagree with that, but how do we get teamwork that is safe, that has that humility that you talk about there, that has competence but humility? You mentioned simulation. I think that's a great example, but it's sometimes maybe a luxurious example. There's other things we can do as well in encouraging good teamwork and team performance?
Yeah, so there are many things, right, that have been studied to show their role in changing communication. And the essence of this is communication between healthcare providers and having psychologically safe environment. So essentially, psychological safety is when a team member can get their opinions across to the team without fear of repercussions or retribution, and really having an environment where that psychological safety exists has been something that we are working on. We aren't there yet, for sure. I think there is still a lot of hierarchy in healthcare, but getting there, I think, has been a fabulous journey. So essentially, poor communication is a well recognized factor for adverse events in the healthcare setting. And so, in the past few years, there have been advances like structured, standardized handoffs, for example. A lot of the breakdown occurs during change of shifts. And so, basically, trying to make sure that we, in a concise, clear way, communicate the acuteness of a child's illness to the person that is going to be taking care of the child when my shift ends. So, just to give you an example of something straightforward that really works, is the IPASS acronym that we use for handovers or handoffs. The I stands for illness severity, the PASS stands for patient summary, action list, situational awareness, then contingency planning, and then the synthesis by the person who receives the information to make sure that they understand what's transmitted. And really having a very concise, standardized format for communication helps us make sure that nothing important is slipped, right? Like the gravity of the child's illness is clearly communicated. So that, I think, is a pretty straightforward tool that people can start using right away. Then, of course, you have simulation-based training where it's identified as a really effective methodology to develop technical skills, communication skills, in a way that really doesn't put a child, a real life child, in discomfort. You're practicing these skills without the risk of stress or harm to a child.
Yeah, it's important, I think, for tools like the IPASS tools. The evidence base for these tools is quite remarkable. There are studies to show that you can reduce errors and even harm by a significant percentage by, like you said, putting these structures into practice. And the challenge often, though, is how do we get these things into practice? And do you think, are there methods and approaches we can use? I'm thinking here of things like quality improvement as a way of getting what we know are good practices into a reliable way of being practiced.
Yeah, so of course, there are quality improvement methods, and one that comes to mind is small scale tests of change. So, just using, for example, if your team isn't using the IPASS tool as yet for shift change, just basically trying it out in one or two patients the next time you're on service on the wards is a quality improvement methodology where you just let people experiment and test the change without full scale, full on commitment. The other thing I think that really is part of quality improvement approaches is incident reporting systems have been there for a really long time, but are really underutilized, especially in the pediatric setting and especially in the outpatient setting where I spend the majority of my time. Really, one thing that I try to do as part of my work, I'm a teaching faculty where I am, and I think the next generation of learners really have started off learning quality improvement in medical school and when I trained many years ago. So, really inculcating some of these concepts into their early medical education, I think really changes culture. And so that cultural change is part of our quality improvement emphasis, where we focus not just on convincing the unconvinced, but actually trying to see what we can do upstream and train our future generation of pediatric healthcare providers in a way that really is aligned with safety priorities. So, for example, having them report incidents, having them understand that this is for learning, and showing them that we use the incident reporting system not for punitive reasons, but to actually change and improve quality, I think is an area of emphasis that I've focused on for the past decade or so.
Yeah. So normalizing this approach, and I think as myself and Peter Lackman said recently in a paper, inserting quality and patient safety into the genome of healthcare workers. How do we do that? In terms of safe systems, there are other methods and approaches out there to help us. And I think something we've become more interested in recent time is human factors. Do you think that has a role in helping pediatric and neonatal safety?
Yeah, for sure. And the human factors, I noticed you had a large conference in Ireland recently just around human factors in healthcare. And that's essentially, the science of how people interact with each other and interact with the environment around them, and really gives us well-rounded, holistic view of what's happening in healthcare. That has been a major part of how we've been thinking in healthcare, understanding that health systems need adaptation, they need flexibility. You come into work every day, and that day is going to be most likely absolutely different than your previous day. Your patients are different. Sometimes technology changes, all of that. Approaching your environment with that understanding and understanding how you interact with the environment, there is going to be variation. And then just being adaptable to that variation helps us do a better job. And then, of course, there's developing technology around that understanding of human factors, right? Like when we started off in pediatrics, John, you and I, we don't know how old you are, but I'm just venturing a guess that we didn't have really programmable infusion pumps. We didn't have these automatic dosing calculators that just calculate the accurate dose.
I'm certainly that old.
Background.
Yeah.
Yeah. We didn't have these like tubes that won't go into the wrong connector and just
Yeah.
go into the right connector to prevent us from giving the wrong type of medication in the wrong administration fashion. So again, all of this, I think, stems from an understanding of human fallibility, right? And its limitations, and then using technology in a way that fills in those gaps and makes it easier for us to do a good job in our workplaces.
Yeah, absolutely. And I think you forget how much progress has been made from taking very even simple human factors ideas, like the simple design of storing things. When I started work, the KCL was stored beside the NaCl in the drawer, and it was easy to make a mistake. Well, but I'm conscious that we talked a little bit about pediatrics in particular. One of the themes of the campaign message, again, is that children aren't small adults, but neonates aren't just small children. They're different altogether. What do you think are the important things that we need to keep in mind for making sure that there's safe care for every newborn?
Yeah, neonates are a special group indeed because their physiology can rapidly evolve in hours, right, as opposed to days. One thing that comes to mind being an outpatient healthcare provider is when these newborns, especially the ones that are fragile in the hospital or the ones that are born premature or those with complex health conditions, now enter the outpatient setting and run into issues and then end up seeking care. For example, a community urgent care or general hospital emergency department. I think that's where there could be issues that people run into, right? Like, I can't tell you about the number of healthcare providers I've encountered over the years that are used to providing adult medicine care in general hospitals that tell me that newborns scare them. And they scare them because, and you've heard that too, right? They scare them because I think that they are worried about interpreting symptoms in a way that could be erroneous just because things are so unclear and ambiguous at that stage of a child's development. So I think that change, the transition of care between the ICU setting with its really specialized providers and mostly a better staffing situation than when they are outside in the community, I think is where there is room for improvement and is a definite area of future research. As you mentioned, there have been immense advances. Life in the world of healthcare safety is much better now than it was 2 decades ago, but definite areas for future research.
Yeah, like you say, we need to make sure that we recognize they are different and have different risks and perhaps different things. But again, teamwork and communication and involvement of families are all going to help all of those things. Well, in fact, we're running out of time. And I suppose just before we finish up, looking into the future and maybe a wish for areas of research that you think would really make a difference, or are there projects you're working on that you would like to tell us about, you think are going to be, maybe when we come to look at this list again in another few years, what are going to be the important things in the time to come?
Yeah, the list is large and is still growing, but a couple of areas that I'm working on being an outpatient doctor is communicating with patients in a format that works for them. So this generation of parents that I'm working with are really digital natives. They've grown up around using technology for communication. They basically have their computer, like their smartphone, with them at all times to reference information, health information, and come in with health information, right? So basically, trying to see what are great ways of communicating with this generation of parents and trying to use telemedicine, e-consultations, the electronic health record, messaging portals, all of that really effectively, there's chatbots. So
Yeah.
basically, digital health is here and is used already, but using that in healthcare to make sure our kids receive great care.
And how we get the most out of it. Fantastic. Well, it's been a real pleasure to talk to you and to share your interest and knowledge in pediatric and neonatal patient safety. And as we come to the end of the episode of the Walk and Talk Improvement podcast in collaboration with Mapping Healthcare, for you, the listener, I hope these insights will help to inspire you in your work and to improve health and social services wherever you work. Ulfat, thank you. It's a real pleasure to have had the chat with you today. I look forward to seeing you soon.
John, it was fabulous being here, and I really am grateful for the invitation and the opportunity to speak to your listeners.
Thank you.
So that was Dr. John FitzSimons and I talking about this year's World Patient Safety Day theme: safe care for every newborn and every child. Patient safety in pediatrics is a complex yet critical area. A problem that makes it even more challenging is the fact that the funding and incentives to develop pediatric-specific clinical guidelines and run clinical research in child health lags behind the resources our society invests in grown-ups. By taking the time to understand the unique needs of children and researching and implementing solutions customized to their needs, we can work toward a future where avoidable harm to our children is eliminated and healthy kids become healthy adults. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. Please connect with the show on Instagram at Mapping Healthcare to share your thoughts and ideas for future episodes or guests. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts. If you enjoyed this episode, please don't forget to subscribe and leave a review.